The earlier the intervention, the better the outcome. And now with all the advances in general anesthesia and the neonatal care and all that, we are able to intervene these children at a very earlier age. And the recommendation for unilateral cataract will be 2 to 4 weeks, and for bilateral cataract will be 6 to 8 weeks. IOL calculation is again a controversial topic in children because we do not have a specific customized IOL power calculation or a formula for pediatric cataracts. So we were using Hage's formula or the Holiday 2 formula, but more commonly the SRKT formula is the one which is being routinely used. But now for the past 1 year in Aravind Coimbatore, we are using the Barrett's 2 universal formula, which is promising results, and their prediction error is also much lesser, but then we still have to wait for long-term results. And this is a paper I wanted to share with you. As I was going through the literature, this was a study done looking at the accuracy of the universal theoretical formula for pediatric intraocular lens implantation, and they did a study to compare the accuracy of Barrett Universal 2 with other formulas. And this was done in San Francisco in the Children's Hospital, and their results were like 64 eyes of 64 patients between the age of 1.5 to 15.5 were included, and their prediction error was very low, about minus 0.22 diopters. So they concluded saying that it is either superior or similar to the SRK2 formulas. So it is definitely a recommendation, and with our personal use, we have seen very small prediction errors, and we feel it is reliable, but we're doing a study, we'll come out with the results, and I'll be able to confidently say in my next presentation. Then the choice of IOLs again, we all know that monofocal IOLs are time tested because they give minimal aberrations, because children are very subjective. You can't expect in very small children because they don't communicate to you. So, but so far we have had very good results, and we prefer PMMA rigid, now the foldable hydrophobic acrylic, and very small children we prefer a 3-piece lens, because later on with the myopic shift is a need for a IOL exchange. It's easy to do an exchange in a 3-piece lens. But then now in little older children, about the age of 10 years, the new generation IOLs like torics and multifocals and the extended depth of focus lenses also have a role in these children. Then positioning of IOL, we only thought about in the bag lens because that gave the good outcome. But then we have sulcus fixated options also now, because these 3-piece lenses have been doing very well. We have 20 years data now. They are very well settled and they do not cause any problems. Then iris claw also is becoming very popular because technically it's much easier to do iris claw lens, especially in lensectomies and in a subluxated lens, ectopia lentis, it's a good option. So you can either do, you can see here, it's either above the pupil or it's retropupillary. And the other one is the optic capture. I'll be showing the video. And the bag and the lens, this was popularized as Mary Tassignan. It's more popular, she's from Belgium, more popular in Europe, but then other countries, not very popular. It's a very special lens with a ridge. So they call it the bag in the lens. So that is also a positioning of the IOL. Preoperative evaluation, like the routine evaluation, but then we have a lot of advancements with the equipments. We have all the imaging system. So it's a lot more easier, like UBM and OCT and all that stuff. So it's easier to diagnose if there is a pre-existing posterior capsular dehiscence. You're prepared to how to deal with those children. So this is just a simple cataract surgery I'm showing. Do you have a pointer? Okay, so this is just to show you a simple surgical technique. So, most of the children, it's a clear corneal incision, and you can see it's only a 2 millimeter incision. The phaco machine, we have the, thank you. We have the irrigation cannula. So you just remove the cortex and then put the 3-piece lens in the bag. And the 23 gauge vitrectomy is a very good help. So, through this small incision, you do primary posterior capsulorhexis and do anterior vitrectomy, and the wound is closed with the 10-0 vicryl. So this is normal. So you can see how advanced this is. It's a lot more easier and simple, and the next day child's eye is quiet, and we normally give subconjunctival decadron. And also the advent of using the intracameral antibiotics and mydriatics has been very helpful. We hardly see any case of infection. Endophthalmitis has become very rare in children, mainly because of the use of antibiotics, and then they're looking at no drop surgery, then all these steroid depot injections where there is a compliance to applying the drops. This would be helpful. So these are all the changes which are happening now. but still not practiced. We have not given any depot injections for, still rely on drops, and children are quite comfortable with the eye drops and the ointments we give them. And multifocal IOL definitely is a requirement, because the first question the parents ask is, my child will have to wear glasses for lifelong. So, you know, but then only thing is you need to have precise biometric measurements. You can only do it in older children, and always aim at emetropia with the plus 0.25 or 0.5 diopters of residual hyperopia. So we have done some multifocal IOLs. Little older children, now we advise a multifocal IOL. I was using the Varion guided system for the centration of the, you know, the rexus. So this was an intumescent cataract. She was a 12-year-old. So we attempted to do a panoptics lens. What is important is have a good rexus. So the Varion guided system gives you it's a smaller rexus. Because of intumescent lens, I attempted to do a small rexus. And now I'm enlarging the rexus. And then this you have to be very cautious. Unless you're comfortable, don't attempt for a posterior rexus, because sometimes it can get extended. So that's multifocal IOL. And torics in children, do they have a role? Yes, definitely. Especially when have children with a high astigmatism, you can definitely recommend a toric IOL. And because if there's a pre-existing high astigmatism, again, you know, there's a chance of amblyopia. This is a child here who had, you know, astigmatism of more than 2.5. So we attempted to do a toric IOL in this child. Not that we do very commonly, but then now at least we have an option. And these children who we have operated are doing very well. So again, more emphasis to, you know, do the rexus. So the same thing, and just that you have to place the toric lens, and if you're sure and comfortable, you can do a posterior capsulotomy. Thorough cortical cleanup, because the posterior capsular opacification is one complication following cataract surgery. So we do not have much options other than doing a primary posterior capsulotomy or a post-cataract YAG capsulotomy. So this is a toric IOL in a child. So this optic capture technique, though it was popularized by Howard Gimbel way late in I think early 90s, I think it's getting a little popular now. They say the lens epithelial cell. This surgery I did last week. This boy was a myopic boy. The IOL power was +7. So he was an 8-year-old boy. So normally I put the lens and do the PPC. This child, because we are going to do a posterior capture, I did the anterior rexus and the posterior rexus. Little bit, I didn't want any pressure, so I extended the wound a little bit. So you can see here a 3-piece lens. I'm lifting with the side port the anterior rexus and then putting the lens in the bag. I'm only using HPMC, I'm not using Healon or Viscoat. With gentle manipulation, I put the lens in the bag and trying to push you can see now, the optic. Now I'll demonstrate. You can see gently pushing back the lens behind the posterior rexus. And you can see very well that, just give me one more minute. So you can see there, that's the anterior rexus, and that's the posterior rexus. So that's you can see now, that's anterior and that's the posterior. So the lens is beneath the posterior rexus. So this is the optic capture. So that's mainly because they say it prevents PCO. And again, what the technology has helped us is, this is a case of a persistent pupillary membrane with the anterior capsular cataract. So before, this is what we used to do. Can we also run this video? For want of time, I'm just running this. This maybe like 4 or 5 years ago, if I see a case like that, I would have attempted to go and do the cataract and place a lens. But now we've started, I tried in one of the cases, it worked out well. Because of the finer instruments we have, we just removed the membrane, ma'am. This child was about 3 years old, and only thing is he's amblyopic. But then you have kept the lens with the occlusion therapy, they're going to do well. So if you see gently, you just remove all these, this pupillar threads, and then very gently peel off the membrane. You have to be very careful, because, but you counsel the parents that sometimes I may have to go ahead and do the cataract surgery. So just peel off. And this child has been followed for almost 3 years now. There is no opacification. The lens is clear. So this is all the recent advances, I would say. And then rehabilitation follow-up is a lot more, easier now, and awareness is more in the parents. But still, we do have people coming in late. But then the treatment, the drugs, everything has been a lot more easier now. And we give them, bifocals. That's very important. And this was a very interesting thing. The cataract system, this was mainly in the African countries, especially Nigeria. They have a tracking system for the trachoma. So they followed the same thing, because we all know as pediatric ophthalmologists, just doing the surgery is not important. Follow-up is very important. So they developed a system called the cataract system, wherein, this child, every child is followed up. So they know that, if there is a failure to follow up, they will call and ask them to come. So this is a dashboard they form. This gives the male-female ratio, then the surgery done, and this is the patients, the number of eyes operated. So this is very interesting. I think this will be a good tool for following up our patients and also to maintain the data. Again, artificial intelligence, I saw papers on artificial where they have, this advanced technology has helped us to, even people in remote countries, when to intervene, what type of IOL power. So all that can be used with the artificial intelligence. And then not only that, now they have all studies doing, the stem cell research is going on to prevent cataract formation. And then they have tried these dry drops, and they say it's promising in dogs that, clear up the cataract. But this is all in the pipeline. And future, we are looking at customized IOL formulae, and then there's no specific IOL, which is, but the people do make it for you. If you ask, then there are some companies who make it for you, but still it is not available. And then PCO, again, a lot of studies on 5-fluorouracil and this, but then nothing really is working on preventing the PCO formation. And intrauterine detection is also, again, a thing just you have to keep in mind. At least if children can be detected at earlier age, the rehabilitation will be better. Thank you very much. Thank you, Madam.
Thank you, Madam, for that fast and exhaustive coverage of updates in pediatric cataract. Now I call upon